My favorite modifications for knee pain during single-legged exercises. Oh! Okay, so what kind of knee pain are we talking about? Generally speaking, these modifications can be most relevant to things like patellofemoral pain, quad, or patellar tendinopathy, Osgood-Schlatters. However, they're also going to work for folks who have meniscus pathology. Let's say you're recovering from ACL reconstruction, so on and so forth, right? And if you have a patient that has a really aggravated knee, things like split squats, things like step-ups, single-legged squats, feel god-awful. So today, we're gonna talk about how to do two things. So one, how do we find the modification for your patient? Allows them to continue working towards your training goals. And when we find that right modification, it's actually going to serve as an excellent rehab exercise too. So how do we know when we found the right training modification? Let's say you have a patient that have patellofemoral pain, they go into the gym, they're supposed to do split squats, and they try to do it, feels pretty bad. What do? Should we modify it? Do we not modify it? Generally speaking, I like to use the pain monitoring model. This was popularized by Karin Silbernagel. The initial research was in the Achilles, but it's been reproduced in a lot of different areas of the body. Essentially, if your patient is performing the exercise and the exercise is going to produce a 4 out of 10 or less while performing the exercise, that night, the next day, the pain is back to baseline, and that's a good exercise. We don't have to take that out of the patient's program. But the movements do produce more pain, right? So let's say it's a 5 or 6 out of 10, and the next day, patients are more sore, more painful than they normally are. It's probably too much. We're gonna need to modify those things. And largely, we want to change our patient's program as little as possible. If a patient is supposed to do split squats and the knee is hurting, and you just give them barbell bench press, way too big of a modification, right? We want to change the program as little as we can. So if, let's say, a full range of motion split squat doesn't feel great, we do a partial range of motion. Maybe we're not getting that full range of motion. Maybe we're getting a little less hypertrophy, but we're still working towards the patient's training goals, right? If you have a patient with knee pain and you just overload them with upper body exercises, sometimes you hurt something else in the process, all right? So choose that variation that's as similar as possible to what the patient is supposed to do that day. All right, so what's the first step in modifying exercise for patient to have pain? Actually, it's not modifying the exercise. It's attempting to modify the load. So you have a patient that's supposed to do reverse lunges and their knee is hurting a lot. Can we modify the load in a way that allows them to continue training for that day, right? And there's a few things we can try. The first of which is going to be altering the rate of perceived exertion, RPE, or the reps in reserve, RIR. Now we have some pretty cool research to show that from a strength perspective, if you push people to failure, or you're pushing them 1 to 2 reps shy of failure, or if you push them 4 to 6 reps shy of failure, the improvement in strength is very similar, if not exactly the same. And the one study I'm mentioning, I'll leave a link in the show notes, actually showed that if you leave a few reps in the tank, you perform better than going to failure, right? So if all you have to do is change that rep in reserve in order to reduce the pain, to be in those parameters, that's the first thing you're gonna do, right? Let's say that doesn't work. The second step is we can start to mess around with either the movement, speed, so adding a tempo, let's say 2 seconds on the way down, 2 seconds on the way back up, or we increase the repetitions. So if your patient's supposed to do 6 rep max, right? We try to alter the RPE, doesn't work. We take the reps, bring them up to 12. What happens when you raise the reps is the loads have to drop. So you might actually be able to get a really good training effect if you alter these two things. The problem is when you start messing around with the movement speed or the rep range by bringing it up, we start to lose out on some of those strength gains, but we usually have a very similar increase in hypertrophy. So again, we're trying to change the exercise as little as possible. Okay, so 2 really important things to keep in mind when dosing exercises with your patients. The first of which at the knee is that generally speaking, the deeper we go into knee flexion, the more stress on the knee. Now this varies from pathology to pathology, but largely you'll find this is true for most patients. The second piece is going to be a little bit about physics, right? We all know that knees over the toes is going to put more strain on the quad, on the knee, but why is this? So we can think about this from a physics perspective. So let's have Jackson go ahead and stand up on this box here. He's going to do a single-legged squat and then just pause at the very bottom. So go ahead and squat down, good. What I'm gonna do is take this PVC. This PVC is supposed to represent his center of mass, okay? And largely, the line from the PVC to the knee represents the moment arm at the knee. So the larger this moment arm gets, go ahead and shift that knee way far forward, the more strain is gonna go on the quad as well as the knee. Now go ahead and shift your weight back. This moment arm is actually much smaller now. But what happens is that on the flip side, from the center of mass to the hip, the moment arm for the hip now grew. So whenever you have patients do an anterior weight shift and bring that knee forward, torso upright, more work for the quad, more stress in the knee, generally more pain. And when we send the hips backwards this way, it's generally going to be more work for the hip, less for the knee, and usually feels better for the knee.
You know, my patients keep telling me that they have pain right behind the kneecap. Hurts when they squat, hurts down the stairs. I think it's patellofemoral pain. What the hell does the research say about patellofemoral pain? PubMed.com. All right, there we go. Okay, excellent. There's 335,000 studies to read. Gosh, too much. I'm getting frustrated.
Whoa, calm down. No need to be frustrated. This is Dan Pope. And I have fabricated what I believe is the perfect solution to your problem. It is the patellofemoral pain evidence-based cheat sheet. And I'll catch you up to date on patellofemoral pain under 10 minutes. Well, I'll tell you what, Dan, that's actually pretty helpful because I'm kind of dumb and I don't like to read. Well, don't you worry, I'm dumb too. But when it comes to patellofemoral pain, I am not. We're gonna go over all the greatest hits. Definition, anatomy, what the heck is the pain generator? Are there any risk factors for this condition? What's the prevalence and clinical presentation? How about mechanisms of injury, differential diagnosis, how you even go about diagnosing this? And then our favorite, evidence-based treatment. So that's my promise. I'm gonna get you up to date on patellofemoral pain under 10 minutes. I'll leave a link below in the show notes in the description. Go ahead and click on that link and get to learning. So the first exercise we're gonna go over how to modify is gonna be the lunge as well as the split squat, okay? We're gonna start with, which is typically the most challenging for the knee, that's going to be a forward lunge. Now, keep in mind, before you start modifying the variation, think about the loads. So essentially we can take some weight away from Jackson here when he's doing his split squats and lunges. We can think about changing the tempo. We can do a lot of different things before we start to even modify these, right? So let's just think about the forward lunge first. You mind doing a few reps for me, Jackson? Good, and press back. So in the forward lunge, and you take a breather now, Jackson has to stride and then decelerate with his knee and quad when he steps, okay? Because of that, this is usually a little more challenging on the knee. We want to modify this, and it's very easy to do this. All we do is step backwards. Just take a step forward so you're still in view here, and then take a step backwards, descend towards the floor, and come right back up again. Yep. So a little bit less stressful on the knee. Now, we can make this even less dynamic by just doing a split squat. So essentially, just staying in place and descend down and come right back up again. And I would say you're probably about a 60-40 split. About 60% of the work is the front leg, 40% of the work is going to be on the back leg. The next thing we can start to mess around with a little bit in our split squat is going to be your stride length. So let's go ahead and have you set up with a nice long stride, just like so, then descend towards the very bottom. Now take a look at the knee flexion angle here. What I want you to do is shorten up your stride a bunch. See how much more that knee is now traveling forward? So what we're probably doing is we're causing more knee flexion, and we're also creating a larger moment arm for that knee now. So just makes it more challenging for the patellofemoral joint. The next thing we can do is we can take an RX pad and can reduce the range of motion that Jackson's going down with. So let's go back to our split squat. We'll descend down and then just go ahead and tap your knee. Yep, so you can see very easily we can increase the challenge just by taking some RX pads away, and we can decrease it by adding more and more just to make sure you hit those pain parameters. So a really sneaky way to help me out while your patient is doing their split squat repetitions is you steal their phone, open up to the fitness pain-free channel. When they're doing their repetitions, go ahead and just take that phone, slide it down, and surprisingly, the knee is not as good at tapping buttons as the finger is. So you might have to prescribe some higher repetitions. Just see if you can place that phone, try to hit that like button, maybe subscribe, leave a comment, help that algorithm out, all right? It helps me. Next, let's talk about the step up. So the easiest way to modify the step up is going to be increasing or decreasing the height of the box. Let's have you do one repetition here and then pause at the very bottom. Good, come on down and then pause. So if we flip the box, pick up that foot just a little bit, and right back down again, you can tell that the knee flexion angle changed. So essentially, we're not going into as much knee flexion when you use the lower box. So super easy. The other thing that we can do is we can alter the amount of weight shift we have anteriorly versus posteriorly, right? So if I have Jackson start off by saying, hey, bring your knee towards me, keep that torso stark, nice and upright, and then step up from there, good, and right back down again. We know that we're putting a little more strain through the hip, through the knee. Might be causing some more pain with your patients that have a lot of irritation within the knee. If I do the opposite, so say, hey, don't let that knee touch my hand, and then step up, and then right back down again. What ends up happening is that the posterior weight shift is reducing some of the strain on the knee. Another easy way to apply this same cue is by putting something next to the box, all right? So go ahead and perform a step up for me, and then make sure that when you step back, you don't land on that RX pad. So when I have Jackson try to step back over top of this RX pad right here, right, this balance board, whatever the heck it is, we're causing a posterior weight shift. We're putting some more strain on the hip, a little less on the knee. So a very easy way that we can reduce strain on the knee. If we want to amp things up a little bit, I can also have Jackson start with his foot right next to the box, and when he performs a rep, I want you to slide your toe along the box all the way up and then all the way back down again. And what this does is keeps Jackson forward, anterior weight shift, increase some of the stress on the knee. So whatever modification you need for your desired end result. Now, this next trip is going to work with the split squat, the step up, and the single-legged squat, which we're going to go over in a minute. You can also add some assistance with the TRX. I love these a lot in my post-op patients when they're allowed to start doing single-legged training. We usually introduce these movements with the TRX to make it a little bit easier, and your patient can help as much or as little as they want to with their lower body. I'll often combine these really easy movements with some blood flow restriction training as well, just because if you have to really ramp down the challenge of the movement so it doesn't aggravate your patient that much, you're usually losing that strength and hypertrophy effect. If we add the BFR, we bring it right back up again. So really good modification to give a shot with your patients. All right, next is going to be the single-legged squat. Now, a very easy way to make this harder or easier is just by altering the height. Let's do 1 or 2 reps here, Jackson. Excellent, good, take a breather. And then we put the RX pads behind. Yep, do a squat. So you can pretty easily see that we're just decreasing that range of motion a little bit, right? The other thing that we can do is we can change the moment arm at the knee. We can do this in a variety of ways. I like to do it through cueing. So the first of which is I can tell Jackson, hey, stay nice and upright and sit straight down to the bench, right? And if I do this, I'm gonna drive that knee forward, which you can cue your athlete, hey, keep the heel down, drive the knee forward, and I'm putting more strain on the knee. If I want to reduce some of that strain, let's take about a half a step forward. And then when you sit down to the bench, think about sitting back to the bench. Very good. You can see he's translated his weight posteriorly. I think for most athletes, when they have them sit back to a bench, they're automatically thinking about a posterior weight shift anyway. So we have to cue them up to bring the knee forward if they're not getting the desired end result, right? The other thing we can do to reduce strain in the single-legged squat is we can add a kickstand, right? So essentially what we do is take your left side leg forward and put maybe about 20% of your weight into that side, Jackson, but about 80% is on the right, and perform a squat and assist slightly with the left side leg. Very good. Now, I usually will introduce my patients after major lower body surgery, like let's say ACL reconstruction, with kickstand variations, as well as a TRX assist. But over the course of time, as they're getting stronger and stronger, obviously we get rid of the kickstand, get rid of the TRX, and we start to go from high heights to lower heights. So let's say you're trying all of these exercise variations, you're having very little luck. So everything is really killing your patient. Feels horrible, pain is greater than that 5 out of 10, makes your knees scream the next day. What can we try? One of my favorite tried and true exercises is a single-legged Romanian deadlift. Jackson, you mind trying 1 or 2 of these? Very good. Now, we can use this when your patients are hurting a lot, and we can also vary this a little bit to get more or less knee and quad. So we do this by cueing either more or less knee bending. So Jackson, on your next rep, I want you to do 1 or 2 reps where you're bending the knee more as you go down. Not too much, don't hurt that knee. Very good. 1 more. Excellent, take a breather. And on this next set of reps, keep it a little stiffer. Maybe a slight knee bend, but not very much, okay? So this variation is going to be a little bit more hip dominant. So if individuals have a lot of knee pain, this is usually going to be tolerated a little bit better. So if your patient doesn't tolerate any of these single-legged variations, you can give the single-legged deadlift a try. As they start to tolerate a little more loading, we go into more knee bending, and then we'll try one of those other exercise variations as they progress over time. All right, so you got the single-legged modifications you can use with your patients. You still need to make sure that you're diagnosing the patient appropriately and giving them the right treatment for what you found. So the most common form of knee pain, patellofemoral pain. I'm going to leave a link in the corner. We're going to go over everything that you need to know about patellofemoral pain. Go ahead and click on that link, and I'll see you there so you can continue your learning.